Good morning. My name is Dr. Nathan Parthasarathy. Dr. Klepak actually invited me today to speak to you guys about partly who I am, what I do, my job, and what I do specifically in women's health care. The main thing that I want to talk to you today is specifically feminism and being a young OBGYN in rural Maine. Kind of give you some background. I live in Skowhegan, Maine right now. Got my very first job. Just finished residency training 5.5 months ago. I'm from Louisville, Kentucky, and growing up, I had no idea what I wanted to be. But my parents were just like, "You're Indian, so engineering, medicine, you got two options. Choose one of them." So, despite that, when I was growing up in Kentucky, there weren't any really good role models for me to kind of look up to kind of figure out what I really want to do in engineering or want to do in medicine, because my family is a family of immigrants. We came to the United States and we kind of had to figure it out. As I was growing up, I was interested in science, but I was also interested in art. And when I went to high school, I decided I wanted to just, play it easy, and then went to the school that was in my town, which is the University of Louisville. While I was there, I kind of just took every single possible class, trying to figure out what I wanted to do. I wanted to just figure myself out. And when I graduated with a degree in philosophy. My third year of undergrad, I still had no idea what I really wanted to do. And so my parents said, "You got 4 years to figure yourself out. Figure it out." So I applied to medical school and I ended up getting in. And then I started this next career of trying to figure out what I wanted to do in medicine. And it was in the course of that I kind of learned about myself and what I wanted to do with my life. And so to kind of start, if you want to get a career in anything, career in X, career in Y, you got to have to figure out who you are, what your personal preferences are, what you want your environment to be, and then hope that it aligns with what your goal is. In this case, I kind of just brought up some random things: interest, values, your own personality, and skills. If you're exceptionally introverted and you're really afraid of public speaking, you probably shouldn't go into a field that requires public speaking. If you're very, very extroverted and you're not really good at focusing on one specific thing, you may not want to go into microsurgery, and because that just requires 7 hours of working on one little space about that big. So, but when you're trying to decide on a career in medicine, some of our mentors in medical school were trying to talk to us about how to make that decision, because there's over 120 different careers within medicine, whether it's neuro-oncology, whether it is MRI-based radiology. And they said, why don't you look into the types of things that you may like, whether it's practice settings, the type of conditions that you want to treat. And then they use Venn diagrams. And this is the Venn diagram that I was shown. Pretty much what your current job is as a medical student, what your ideal job would be, and you just have to kind of imagine what it's going to be, and then try to maximize the overlap. And within those 120 careers within medicine, you'll be able to find that one that maximizes that overlap and that shade. And so I looked at medicine versus surgery. What's going to give me the most of both worlds? Inpatient versus outpatient. Generalist versus specialist. And the one thing that I liked about obstetrics and gynecology and women's health is that it maximized one entire, half of the population, which is women. And we take care of women or girls from infancy all the way till ladies when they are about to die. And the oldest patient I have in Skowhegan right now is 101 years old. And she comes regularly every single year for decades. And so that actually kind of helped me realize, what are these Venn diagrams that I'm putting together? What do I want to be in terms of a physician? Because there are jobs like radiology, and I know that you guys are looking at the skull, and a radiologist specifically looks into the different things that happen inside the body, but they're also a physician that doesn't really interact with patients directly, as does a pathologist. They don't really interact with patients directly. They interact with tissue samples. And And so my goal was to maximize patient interaction. It was to do medicine, do surgery, and take care of everything. And the only classical physician role that is still out there today that does all of these things is obstetrics and gynecology, which is one of the main reasons that I went into women's health, was so that I could be kind of a go-to for every single concern. And the next thing I want to talk about is the glass ceiling. As a male physician in obstetrics and gynecology, it's really different because I'm a women's health specialist, but I'm a male. So we have to kind of look back into what the history of medicine was back in the day. The glass ceiling is something that we've heard in women and gender studies to represent the obstacles that different minorities have to overcome, but specifically in this case, women had to overcome over the course of the decades to get jobs in medicine. Throughout all of history in women's health, there's always been midwifery. Women were the attendants of childbirth. They didn't invite men into it, including the pharaohs, including the kings. Women were the attendants. Back in 2700 BC, there was this woman named Merit Ta, and she was historically the very first physician on record. And so there is this tapestry. This is from 1800 BCE, and it represents childbirth, and it's always females that are delivering the babies. And you can see that there is a pharaoh, male pharaoh, that kind of stands in the background, but is not actively participating in the childbirth itself. Although it started out as a female-dominated field, as older Caucasian men came into power in the United States, it slowly turned into a male-imposed and dominated career path. Men, back in the late 1800s, early 1900s, said all women should be delivered in a hospital, and in the walls of a hospital, men dominated. That's just the way it was. They created the rules. But in the late 1800s, we started having pioneers in women's health. Dr. Annie Lowry Alexander was the first female physician, licensed physician, to practice in the United States in the South. And in the South, during the time of the Revolution and the late 1800s, men were very, very patriarchal and dominated anything and everything that you can possibly imagine, whether it's the mail, whether it's like post offices, hospitals, every single career possible. Women, in general, stayed at home or entered into nursing professions. She graduated in 1884 and went on to become famous in the treatment of typhoid and diphtheria, which were the primary killers back in the day. Before her was Dr. Rebecca Lee Crumpler, the first African-American female physician in the United States. She graduated in 1860. Both of them graduated from a college in Philadelphia. It's now called Medical College of Philadelphia / Drexel or Hahnemann Medical College. But back in the day, they were. It was one of the most premier medical schools. I think it was called Northeastern, or I think it's like Northeastern Medical College. And it was one of, I think it was like the 8th medical college in the United States after Harvard. So, so when we look at medical school by the numbers, female graduates started to become more prevalent in the 1930s and 1970s. And during that time frame, during those 40 years, there was about 14,000 graduates. And then in the subsequent 10 years, there was 20,000, which is amazing because now women are entering the hospitals and they're becoming the chief of their department. They are becoming they're entering prominent roles in the hospital. And if you look by the 1970s, what the graduation rates are, it's like 9% of women made up every single one of the graduating classes. And today, more women are graduating per class than ever before. Right now, as of 2017, it's 58%. So the tides are turning. Now we've got to look at something else, which is OBGYN residency program. So there's graduates, but then there's the people that are entering into the careers. And between 1978 and today, we noticed that there's an increased number of people that were enrolling and then also matching into residency programs. I make the distinction between enrolling and matching because back in the late 80s, early 90s is when they started the match program. Has anyone ever heard of the matching into residency programs? And so between 1978 and the early 80s, late 90s, late 80s, early 90s, you had to just enroll. You had to apply directly to the hospital, directly to the position that you want, and then you either got it or you didn't after an interview process. And now we go through the residency matching program, which is an algorithmic-based approach, so it's fair. And between 1989 and 2002, the proportion of females that were entering a residency program and completing an OB/GYN residency program went from 44% to 74%, 3/4. But the number that were actually graduating during that time period went up from 33% to 44%. So there was clearly a disproportionate number of women that were entering into women's health. And what do you guys think would be that reason? Does anyone have any idea? There's also more women entering into, a disproportionate number of women that entered into pediatrics and family medicine. Those are the only 3 specialties where there was a disproportionate number of women that entered. So there's a hypothesis as to why this happened, but it's not confirmed. And there's a lot of editorial articles and nothing that's really based on true science. But they were saying that women tended to go more towards maternally based careers, which is not really substantiated because there were also plenty of men that were also going into the same fields. And so that kind of brings up the idea, if more women were going into maternally based specialties, then you would also expect more men to be going into more men-based specialties. But unfortunately, during the time, men dominated everything. So it was really hard to see that. So I want to talk about like gender medicine. So there's 2 different major specialties of gender medicine. There's gynecology. We take care of women. There's also andrology. They specifically take care of men. Has anyone ever heard of andrology? So it's a subspecialty of urology. And urology takes care of the genitourinary system, so kidneys, ureter, bladder, and then genitalia. Andrology is a subspecialty. They look at infertile men, men with erectile dysfunction, men that need prostheses, and then kind of advanced reproductive technologies for men. Both specialties, andrology as well as gynecology, we take care of LGBTQ people as well as trans men and trans women. Me specifically, I came from a program where we did hormone replacement therapy, we did breast surgery, we did genital reconstruction, so that we could help people get the gender and secondary sex characteristics that they desired. And so we deal with that on a regular basis. But the main thing is we need to kind of figure out like what people think about their jobs and whether they feel like they are supported in their jobs and their careers. So I kind of grabbed a whole bunch of quotations from people all across the internet, did some Googling to find out what people thought and looked in forums. And here's some female urologists. And they said, it has become a male-dominated business with discrimination against women. There's other ones that say it is increasingly impossible for females to be successful in urology. And then sexism is becoming the norm, and soon there will be no place for women in this field. And I hate the growing oppressive gender bias against female providers. So I'm sure you can imagine women who have historically been oppressed entering into a field, which is all of medicine, back in the 1970s, who have then slowly got a foothold and got their foot in the door into careers, surgical careers, medical careers, and they're still feeling this way, despite all of the things all of the major gains we've made in society and in politics. Unfortunately, the way that everything has swung is that men are also feeling the exact same way, and it's the young men that are in gynecology today. And so all you really have to do is just change the male and the female, the gender medicines from one way to the other. And actually, all of these quotes are just a blend of female urologists and male gynecologists saying what they think is happening. And so if you change everything to a male gynecologist view, it says it's become a female-dominant business with discrimination against men. And there's no place for males in OB/GYN except in subspecialties. And so the unfortunate thing is that in this gender-based medicine, you're going to have people who have differing opinions as to whether you belong or not. Back in the day, no one thought women should be in medicine. They thought this is a male-dominated field and this is the way it should be. And now it is the exact opposite. We believe that every single person should be welcome in their field regardless of their gender, sexual orientation, age, anything. So to kind of get into what makes a good doctor, do relatable body parts or experience make a better physician? Like, I'm just going to kind of throw it out to any of you. Like, do any of you have any good physician experiences that are able to identify a very specific trait from a physician that you would say would make them a good physician? Anybody? I'm just going to call on someone. Call on you. Have you ever been to a doctor? What made him a good What made him or her a good doctor? Oh. Mm-hmm. Okay. And that's probably one of the most super important things is you want your doctor to listen. There's an entire class in medical school. It's just called listening. It's actually the title of the class, believe it or not. I'm not joking about that. So it's actually just called listening. And unfortunately, it's not just about listening. They don't teach you exactly just that, but they teach you about all the things that you need to pay attention to. Cadence in someone's voice, just cadence in someone's, the way they speak, their body movements, how they put their feet together. It's a lot of nonverbal communication. And so that's a really important thing. As it relates to medicine in general, whether it's pediatrics, radiology, pathology, any of that, you want to know what's going on with the patient. The more information that you can glean from the person that you're caring for, the better off you will be in making a diagnosis, treating the patient, and helping them get better, healthier, or stay healthier. With regards to gender-based medicine, so in gynecology, some people make the argument that if you don't have female parts, if you haven't gone through childbirth, if you haven't gone through menopause, then you're not going to make a good physician. And so all across the internet and all across the research, they're showing that the tides are turning and that no one really thinks like that anymore, especially when it comes to women who are going towards men versus going towards women, women physicians. And so they're thinking, if you're a woman and you have a uterus, then that would automatically make you a little bit more sensitive to other women who have menstrually related issues, who are going through pregnancy, who have had a twin pregnancy, who are infertile. And so I just want to bring up some examples as to when this is not the case. You can be a woman and you can just not have the correct parts. Does that make you less likely to be a caring physician? There's a condition called Mayer-Rokitansky-Kuster-Hauser syndrome, otherwise known as Mullerian agenesis. When you are an embryo inside of the uterus and you are growing, everyone is generically a female until they get the correct signals to turn off all the female parts and convert them into male parts or stay female. And so in Mayer-Rokitansky-Kuster-Hauser syndrome, there is an absence of the uterus, vagina, and the external genitalia. The fallopian tubes, which comes from a different embryological origin, and the ovary are still there. So when you look at the embryological origins, you can see that every single person has these undifferentiated gonads, which will eventually turn into either a testis or an ovary. If you're XY, so if you're a male, then there's this thing called the anti-Mullerian hormone, or otherwise known as testis determining factor, and it will give off a signal, and what it will do is it will then shut down the creation and the generation of all the Mullerian system, which is the uterus, the ends of the fallopian tubes as they connect to the uterus, cervix, and vagina. And then what will end up happening is that those same structures will then become the epididymis, vas deferens, and the seminal vesicles. And so I make the case that just because you have the parts doesn't mean that you're going to be a better physician. Just because you don't have the parts doesn't mean you're not qualified to be a really good physician, especially in gender medicine. Then I make the case of Dr. Leonid Rozdov. Has anyone ever heard of him? He is a surgeon. And so he was, back in the 1960s, he was a surgeon that traveled to Antarctica. And he was unfortunately the only surgeon in Antarctica. And he got a case of appendicitis. And when you're the only surgeon that is in Antarctica and you have appendicitis, you have to take out your own appendix. And so in his case, just because he was under the knife, his own knife, and he underwent surgery, can you make the case that he's going to be a better surgeon because he's had surgery or even had his own surgery? And that's the same argument that a lot of people will make. It's like, you can't be a good obstetrician unless you've had childbirth. That doesn't make any sense. I mean, I just want the best doctor possible. If I want an oncologist, I don't really care whether they had cancer or not. If I want a nephrologist, I don't really care whether they had kidney disease or not. And so that just if you fall into the line of thinking that you need to possess these certain experiences to become a good physician, then you're going to end up thinking that you can't be something just because you don't have the right parts or the right experiences. So if gender has nothing to do with it, then what makes a good physician? I think the main thing that I like to always say is your experiences in life. Every single person is going to have a unique experience. My personal experience is that I was a patient. And I'm going to, last year, exactly about 1 year ago, today is January 31st. January 8th of last year, I just had the worst experience of my life. I was 30 years old. I was in residency. I was my chief year, so there's only 4 of us, and we're in charge. I went into work one day, and this is the beginning of a 48-hour shift. Show up, and then do my rounding, and then I bust out in a full body rash. And then I start sweating through my clothes to the point that not just like your armpits are stained, it's your entire chest, your back, your legs, everything is sweating all of a sudden. I get this full body rash. This is just a picture I got of the rash that I had. So it feels like sandpaper. And it's not just on the parts that are contacting your clothing, so you'd think it may be contact dermatitis because you changed your laundry detergent. It was on my ears, it was on my face, on my forehead, on my knuckles, it was everywhere. So I talked to one of my attending doctors who was in charge of our service that day. And she took a photo of it, she looked at it and said, hey, you probably have a rash. Why don't you take some Benadryl? That's, step 1, Benadryl or hydrocortisone cream. So I thought to myself, okay, if I'm going to do this, then if I'm going to take some Benadryl, then I got to tell everyone else, I'm probably going to be knocked out for the next few hours because whenever you take Benadryl, you're generally going to go to sleep and get drowsy. And so I told my boss, hey, I'm going to go take a nap in the on-call room for a little bit. And I took the Benadryl maybe around 11 o'clock that morning. And then it's 5 o'clock. I wake up and I feel like I got hit by a truck. And my entire body hurts, my muscles hurt, everything hurts. And at that point, I think to myself, I'm not really hungry right now. And I don't really remember peeing all day today. I think the last time I did that was the day before. So then I go and talk to my attending and I say, hey, I still feel ill. I think it's maybe just the residual amounts of this Benadryl. I don't really know, but I got to stay. I got to keep on working. So I managed to muster the strength to go and deliver a few more babies. No C-sections, no surgery, no nothing. And then try to kind of nap it out. So I take another quick nap, I get another page on my pager, and then I go to triage, and then someone has a positive pregnancy test, so I got to go and do an ultrasound to figure out where the pregnancy is. Is it in the correct spot? So I started doing the ultrasound with my intern, kind of showing her how to do the ultrasound. And then randomly, I still remember very, very vividly, she has this weird look on her face and she says, "What's wrong with you?" And then she's literally watching me soak through my clothes and start sweating again. She said, like, I look green. She was like, "You need to go sit down." And so I tried to be strong and finish the ultrasound. And I ended up going and sitting down in triage and just told the nurses there, I was like, "I'm exhausted. Can I get an IV site? Can I get some fluids? I don't think I've peed in a while. I think I'm just dehydrated." And so I ended up going to sleep. And when I went to sleep, I found out like the most comfortable position was this position. And I had to like just prop my head up like significantly and then raise my knees up. And I didn't really think anything of it at the time. I got liters and liters and liters of fluid, finally peed for the first time, finally felt like I was getting better. And now it's the middle of the night. It's like midnight. And I get called for a C-section. And I realize I don't think I can operate right now. I'm way past done. But I don't like, there's no one else in town. I'm the only chief that's in town. All my other friends went out of town. So then I just keep on getting IV fluids overnight. It's now 6 a.m. shift change for the first, second, and third years. And the nurses that were in triage eventually said, "You look way worse than you did before. You came on sweating through your clothes. I had to change my clothes 3 times, all like over the course of the past day or so." And then at that point they said, "You need to go to the emergency department. Like, you're too far gone." So I had to call one of my friends, the other chiefs, to come drive in from New Jersey to cover for me. Once I went down to the emergency department, they ruled out mononucleosis, flu, and then other viral illnesses. They kind of just checked out just the basic stuff. At that point, they realized, "Hey, your liver function tests are a little abnormal. We're not really sure what you have." They sent me home with a fever. They said, "Take some Tylenol, follow up with your primary care doctor." Okay. And so it's still Sunday at this point, and I need to, like, next day is Monday. I need to go back to work. Like, the on-call shift is over. So I go home, relax for a little bit, and then all of a sudden I realize that I just have no energy to do anything. I grab all the couch cushions, put it on my bed. I essentially sleep like this. Don't really eat anything. I have no appetite. I can't even like muster down a granola bar. And then I have to go back to work. And I drive. I have my friend drive me because I can't drive at this point. And I realize that I feel every single bump in the road. And I keep on telling my friend, I was like, "We need to slow down." And he says, "We're going like 5 miles an hour at this point." I feel everything. My head hurts. And slowly I'm just in pain. And so I make it to work and then realize I just need to tell my boss I need to go back home because I don't think I could work that day. Went home, ended up sleeping for an entire day, slept through Tuesday, and then Wednesday morning I have to give a presentation. So I show up to work, I give my presentation, ham it up, get enough energy, and finally my body gives out. I sit down and realize like I can't even move at this point. So I call my doctor up and I go to my primary care doctor's office, who's in the other side of the hospital, and say, "Hey, I need some help. I really don't know what's going on." At this point, like I can't twist my head. I'm like, I kind of move like this. My back hurts, my body hurts. I'm really tired. I have no appetite. And so then they admit me to the hospital directly from the office into the step-down unit before you get to the ICU. At that point, I just started to deteriorate. And it turns out that I had meningitis. I had a horrible headache, cyclic fever, started to vomit. The only thing I really didn't have is confusion or seizures. And once they figured out that I had something going on with my brain, they moved me up to the intensive care unit. At that point, I had to get a lumbar puncture and or spinal tap, if anyone's ever heard of that. The main thing with lumbar punctures is that a lot of people get them because they're ill. We have to rule out every single possible illness, especially the most serious, deadly ones. And if you don't have meningitis and you get a lumbar puncture, that just sucks. But when you get a lumbar puncture and you have meningitis, all of a sudden your head's clear, your headache is gone, the pressure from your brain is gone, you can get up and walk, you feel normal again, you're not hunched over, your neck's not stiff. And so I got a lumbar puncture. When they did the test to look at the specimen, there wasn't any white blood cells in it, so unlikely to be a bacterial infection. There was a little bit extra protein, non-specific, could be viral. And so they were kind of thinking, oh, what else, he likely just has some viral meningitis. So they gave me IV antibiotics, IV antivirals, and were treating me as a meningitis patient. But then slowly they got more and more of my labs back. And what they realized is that when they did a CT scan of my abdomen, that I had ascites. So I started accumulating fluid in my abdomen. And whenever they did that, they kind of they stuck a needle in, drew off some fluid, and then realized that it was sterile. There's nothing really in it. And then I was having some shortness of breath after that, and they realized that I was having pleural effusions, and I had fluid in the pleural spaces, which is the space around the lungs, not in the lungs. And they were just like, okay, he may be having some congestive heart failure, not really sure what's going on, so they did an echo of my heart. And I had congestive heart failure. The ejection fraction of my heart went down from 65% all the way down to about 45%. I don't need a pacemaker at this point because usually the threshold is about 35% for that. And so now they're thinking, okay, we need an infectious diseases doctor, and we need a lot more people on the team. And then I ended up getting hepatitis. And usually hepatitis is caused by hepatitis C, infectious causes, hepatitis B, and these are the different things that could cause it. So they essentially order every single lab test to figure out what is causing my liver inflammation. They rule out all the infectious causes. So I don't have hep C, I don't have hep B. Most people don't have hep B in the United States because you're vaccinated against it. And so they start testing me for fatty liver, autoimmune hepatitis, Wilson's disease. They test my Tylenol level. They test me for every single type of viral cause. And so they're trying to figure out what exactly is going on. It's day 5, and at this point, I have lost consciousness. They had to retap me because more fluid was accumulating around my brain. And so they had to do a therapeutic lumbar puncture. And at this point, as soon as about 20 minutes after they did the therapeutic lumbar puncture, I woke back up. I woke up, I had lockjaw. So I had arthritis in my jaw, arthritis in my toes. I had a claw hand when I woke up, and I thought they probably restrained me or something during this time. Maybe I was kind of out of it for a while. I don't know whether I injured myself. My tendons hurt. I couldn't really move my leg. I was having blurring of my vision. And then at this point, they realized that they're in over their heads. They're calling in a hepatologist to look at my liver. They're asking a gastroenterologist to look at the ascites fluid. They're calling a neurologist for my brain. They're calling an infectious disease doctor for the infection. And the diagnostic mistake that they were making was they were just seeing, in this case, trying to make the analogy, they were seeing individual stars, but they really weren't seeing the constellation. Every single physician is trained to look at a certain constellation of symptoms as it pertains to their specialty. If you have a headache and you're a neurologist, you're thinking meningitis. If you have a headache and you're OBGYN, you're thinking preeclampsia. If you're an ENT, sinusitis. Every single person has a different, if you're a neurosurgeon, brain tumor. And so as soon as I started getting joint issues, they call a rheumatologist, a specialist in joints. And the rheumatologist is also that last line person that you call when you realize you are in over your head and you don't know what is going on. And the rheumatologist I had, her name is Dr. Nancy Walker, was my savior. She comes into the room. She already read through my chart and realized there's a whole bunch of stuff that's going on. She said, "Do you have a picture of your rash?" My attending, who came in that morning and said, "You probably need to take some Benadryl," ended up taking a picture of my ears and my neck. And she looked at the picture and she was just like, "Okay, you have one of 3 things. I need to order some lab tests, and I'm also going to start treating you for all 3 of these things." Treatment was IV steroids. And then she ended up using this thing called the Yamaguchi criteria to rule out all the other two things and rule in this disease called adult onset Still's disease or adult onset juvenile rheumatoid arthritis. Like many pediatric diseases, whenever you have an adult manifestation of a pediatric disease, it's always 50 times worse. Okay? If you think about chickenpox in a kid, you got chickenpox, you get a fever, but then when you have chickenpox as an adult, or you have reactivation of varicella, you get shingles. And it is super, super, super painful. And it's generally incapacitating, and you have to be on chronic medications to treat your nerves. Adult onset juvenile rheumatoid arthritis or Still's disease requires very, very specific criteria. You have to have arthralgias for 2 weeks, fever of greater than 39 degrees, intermittently for greater than 1 week. Typically, you have a rash. Your white blood cell count has to be really elevated with very specific cells being more predominant. You also have to have swollen glands. In my case, my swollen gland was my liver. Abnormal liver function tests. And then you have to rule out the more common diseases, the lower hanging fruit, rheumatoid arthritis or lupus. And so those tests that Dr. Walker ordered for me were to rule out rheumatoid arthritis and lupus. And then you also have to rule out infections. The infectious diseases doctor said, we're literally giving you the big guns right now, and you're not getting any better. You're in fact worsening. And so it's unlikely an infection. He also ruled out HIV. He also ruled out hepatitis, which can sometimes present in really weird ways. They had to rule out cancer, so they ruled out leukemia. They biopsied my liver, and my liver biopsy came back negative. It just came back normal. And you have to rule out all the other easier, lower-hanging fruit rheumatic diseases. And so I ended up with this condition that affects the entire body. My working diagnosis before I had Dr. Walker come in was multi-system organ dysfunction. Nothing was truly failing, but a lot of stuff was going wrong. And once they got the diagnosis, you can then treat it. Pretty much every single rheumatic disease or rheumatologic disease is treated with IV steroids. Give them some steroids, things calm down. In my case, I had additional manifestations that are kind of outside the spectrum of adult onset Still's disease. All the skin on my hands and feet, all the superficial skin on my hands and feet fell off. And then I had a condition called uveitis, which is inflammation of the eyes. I had iritis on one side, and I had scleritis on the other side. That was kind of outside of the normal constellation of symptoms. And so I had something rheumatologic going on, an autoimmune disease that was very serious. So getting sick, becoming sick, and having to call my family, having the hospital call my family to show up, not knowing what the diagnosis was, helped me become a little bit more sensitive to people who come to my office and they're describing their number one most bothersome problem in their life that's affecting their entire life. For me, everything was going wrong. I just needed to submit myself to care because I had no idea what was going on, and I needed everyone on my team. When people come to my office and they're complaining of bleeding, or they just had a miscarriage, they think they may have cancer, they're having chronic pelvic pain, it's been destroying their life, they're having sexual dysfunction, they're having issues with bothersome menopausal symptoms, they can't get through a day without having to step outside and get some cold air, get a cold drink, change their clothes because they're sweating through their clothes. That is their number one problem. And after I became sick, I just became way more sensitive to what people's problems are. I got an understanding for what they believe their problem is and how I can help. Sometimes you need another set of eyes to kind of look at what is going on and help you kind of dissect and pull apart and tease apart all the issues that you're having. So that's that slide. So I also want to talk to you about how things have changed since the late 80s to now and how they teach medicine. Because sensitivity is something that they try to teach you. There's a lot of humanities classes that we have to take in medical school. But the main thing that they really focus on is patient-centered care. The patient makes all the decisions. It's not a hey, I have some OR time tomorrow. Do you want to schedule your C-section? Whether or not you need a C-section or not. Okay, just because I got some time. It's about the patient. The patient gets to decide, and they get to participate in making the decisions. The other thing is what's called shared decision making. And that is where you tell the patient everything that they need to know in order to make the best decision possible. Okay? And then we also get away from what's called the mind-body dualism. Anyone ever heard of Descartes in philosophy? So he had this idea about the mind-body dualism. The mind and the mental are completely separate from the body and the physical. And today we know that if you're depressed, you can have physical manifestations of being depressed. When you are healthy, you'll have physical manifestations of being healthy. And so we know that everything is connected. And so we've really gotten away from this mind-body dualism. And even in psychiatry, a specialty that focuses on mental health, they take a lot of time in trying to teach physical manifestations and how everything is connected. If you want to improve someone's mental health, you get them to exercise, you get them to eat right, you try to fix up all their other medical problems because that will improve their overall health. We've been focusing on preventative care more than anything else. In India, there are no colonoscopies when you're 50 to screen for colon cancer. In most developing nations, pap smears don't exist. That's why cervical cancer is the #1 killer of women. In the United States, we focus on preventative care so we can improve overall health. We talk about community-based health. We talk about population-based health. And things that we do in order to improve community-based health and improve population health is to focus on getting people active. If you think about like Michelle Obama, I think it's what, Get Movin' or Move something. I forget what it is, but that was her main thing. She's trying to fight childhood obesity by getting kids moving. And you got to start young in order to see a huge difference in the future. And so we kind of focus on preventative care as opposed to reactionary care. In my case, last year, I had more reactionary care because no one knew, everyone was just behind the ball in terms of making a diagnosis. And sometimes that's what you have. If you have a trauma come in, you just have to react. You have to just take care of business, figure out what's going on, make a diagnosis, and fix it. We also talk about interprofessional care and how taking care of someone is not just about taking care of the physiology and the pathology that's happening to them right then and there. We want to talk about integrating social work, physical therapists, respiratory therapists. We always have a patient consultant that can come in to help just be the emotional support for the patient regardless of the situation that's going on, because we want to make sure that the patient feels supported in their care. We also talk about team-based care. So all of medicine is a team sport now. Maybe about 50 years ago, the OBGYN and the secretary had one office together. The doctor took care of everything that required him or her to take care of everything. And then the secretary took care of all the billing and the paperwork, etc. It was a chauvinistic time 50 years ago when that's all you could do. The woman was the secretary, the man was the doctor. And now there are about 20 people per delivery that I do. If I'm just having a normal vaginal delivery, uncomplicated, there's me that's taking care of the delivery. I have another person that's waiting, the pediatrician, waiting for the baby. I have a pediatric nurse that's waiting for the baby to assist. I have a resuscitation team just in case. I have my own nurse to help me with the actual birth. I have a separate nurse that's helping support the mom. And so there's just a lot more people that are involved. And I wouldn't have it any other way. This is the way to do it. We have to divide and conquer. And then there's the other thing with the hierarchy breakdown. That's a new thing that we try to focus in on when we're in residency. Is no longer is the doctor in the room is in charge and everyone else is beneath them. It's everyone needs to speak up to make sure that we have the best outcome possible. Everyone talks about birth plans. Every single person is coming in because they're online and they find out that you can just create your own online birth plan, check some boxes. And so they come in, but what they what they don't really see is that the ultimate birth plan is just happy baby, happy mom, go home together. That's it. Okay. They want to focus in on some of the finer details, and sometimes, they miss the finer details. They're focusing on the finer details and miss out on the big picture. And then lastly, we always talk about evidence-based medicine. We try to move away from the dogma. When someone asks you, why are you doing that? And if you say, because that's the way we've always done it, you'll always be wrong. Okay? Everything is changing every single day. And what we're realizing is that the drugs of yesteryear that we were using to treat certain diseases is no longer the way it's moving. Okay? We have found out that, for example, before you got anesthesia, you were told that you shouldn't take any medications whatsoever because the anesthesiologist wants to micromanage your breathing, your blood pressure, your brain function, everything, your heart. And they did a study to show that people that had heart problems and they were on beta blockers were unfortunately dying at increasing and alarming rates whenever they were having anesthesia for whatever it is. And so they did a study and they looked back and they said, well, the people that accidentally took their beta blocker, their propranolol or whatever, those are the people that were surviving. So then there was this huge paradigm shift where it's don't take any of your medication unless it is your beta blocker because your beta blocker will keep you alive. So now the standard of care is take your beta blocker before you get anesthesia. And so the evidence has showed that that's what you're supposed to do. But there will still be physicians out in the community that are not touched by this evidence-based medicine, and they just do it the way they always do. And that is something that you will come across, and that's something that you should kind of talk with your physician about. Because the main thing is that we're trying to educate every single patient so that they can be the best advocates for their own health. Patient-centered care is educating the patients to help them make good decisions about their healthcare to get the best outcome possible. Additionally, we try to support emotions, mental, spiritual, social, and financial. And that's one thing that I always like to emphasize is that medicine costs money in the United States. Most other countries don't have that as an issue. And then when you are performing shared decision making, and I'm going to give you some examples of this here in a little bit. The main gist is that we have to work together and select the best tests, treatments, offer the appropriate things at the appropriate times for the patient, and then balance the risks, benefits, and look at some of the alternatives so that the patient is in control of their care. And when they do this, they're just more likely to follow through with the appropriate care that is recommended for them. And they're going to feel like they are a participant. They're not going to feel like it is the old school paternalistic, you're having some bleeding, you need to have your uterus out. I'll do your surgery, let's schedule for Thursday. If a woman was told that, they'll feel like they have no control. If I was told that from my surgeon or my physician, I would feel like I have no options whatsoever. I'm going to give you, I'm going to give you an example of this. I had a patient that came to me yesterday, 78 years old. She had 2 kids 40 years ago. And because I work specifically in women's health, the concern that she was coming to me for was pelvic organ prolapse. Her vagina was prolapsing through the outlet because things weren't in the right spot anymore. She was coming to me for surgery. This is an elective, quality of life surgery that'll just make her feel better. It's going to make her walk a little bit better. It's not going to make her as uncomfortable. But she also just found out that she has thyroid cancer. She also has rheumatoid arthritis. And she is not medically stable enough for me to do this quality of life-based surgery. And although it'll improve her quality of life, it's not the best decision. I would love to do the surgery, but that's not the point. So I had to guide her in the correct direction saying, hey, if you're willing to deal with this for a little longer, and because you've already failed conservative management, we just should table this for later so you can take care of your thyroid cancer. And part of that is make her understand what her problems are. And if she does want to do my surgery first. I have to guide her along with her other ENT doctor for thyroid cancer to make the correct decision. I never want to make a patient feel like they're getting forced to make a decision. But there's also the issue of like what I'm offering and what's off the table. So there is some physician autonomy. Someone can't just come up to me and just request something. You have to be a right candidate for it. The last thing that I want to like touch on is what reproductive rights are. Rights are rights. You would just assume that they are given to us and everyone has them. Reproductive rights come in two different forms. One is the right of any individual, any couple, to have as many kids as they want, spacing, timing, etc., and also to be able to get the information that they need in order to do that safely. Even if they're having their 12th high-risk pregnancy, they need to get the correct information, they need to get the numbers and the rates of bad outcomes. And that is the duty of the physician. And they have the right to attain the highest standards of sexual and reproductive health. And that means offering the best technology regardless of any type of socioeconomic constraints or your own personal views on the topic. You also have the right to a safe and legal abortion, good birth control, and then access to any type of education. There's reproductive rights and there's reproductive justice. With the justice portion, it is getting access more than anything else. Rights are rights. Justice is making sure that every single person has access to all of this stuff. And then lastly is freedom from coerced sterilization and contraception. Okay, and that's what we try to promote within our field. Does anyone have any questions about any of that? Anything like that? I'm just going to kind of talk about a few different things that I've kind of experienced that kind of fall into this. So a hot button topic in all of obstetrics and gynecology is abortion care. And regardless of what anyone's personal view is on the topic, the main thing is that these women, by the time they show up in your office, are looking to get some help. And my job specifically is to help guide them in the direction that will best suit their needs. Whether it's, they don't have time to go to an operating room right now. They need something quick and easy. They don't want to go to an operating room ever. So I'll have to give them a more conservative option. But the point is I need to offer everyone every single possibility and talk to them about what the follow-up looks like, how much it's going to cost, what the outcome could possibly be. If they have retained products of conception, because they had a miscarriage, you could get an infection. You may want to choose to have the surgical procedure. And also, the thing about medicine is that, again, it's expensive. So even a patient that is coming in that is requesting an abortion may be one of those people that I need to talk to about the financing of it. 75% of all women that come requesting an elective abortion are Caucasian and from a higher socioeconomic demographic. 80% of women that actually get them are African American and of a lower socioeconomic demographic. So we need to kind of figure out how we can even all that out so that we're able to get everyone everything that they want. I've had to tell people, hey, you may want to look elsewhere because this is going to be expensive at my hospital. You have to shop for your abortion. And it sounds weird, but that is the nature of healthcare in the United States. You got to do it. And it doesn't really come down to a pro-choice or pro-life debate. It is you need to help this person. Even if you don't want to do it, you have to refer them to a correct person because that is your job. And your job is to take care of women or take care of anyone. In certain cases, because I thought I'd kind of include this, when I was training, we had a family planning division, and people would come to us and refer abortion care to us under the worst circumstances possible. The patient is on dialysis. She was told she should never get pregnant again because her body would not be able to hold a pregnancy. Because when you are pregnant, the water volume in your body increases significantly, and your kidneys hold and control all the water in your body. If you're on dialysis, a machine has to do that for you, and you end up getting a whole bunch of toxins that are just sitting in your body making everything not work well. And so in situations like that, we then have to talk with the patient, offer every single option. And when we do offer these options, we have to say what the outcome would possibly be. And one option is, hey, you can carry this baby, but your risk of having worsening kidney failure, not getting that transplant, having to possibly dying, or having a miscarriage is X and Y. These are the numbers. This is the possibility of all of these things. So if you don't tell them that, then they're not going to be able to make an informed decision as to whether they want to proceed with an abortion or not. That woman ended up proceeding with an abortion because she actually had her tubes tied, and she got pregnant on accident because her tubal ligation failed. So, and then there are other women. There are other women. One came in, and one thing that is interesting is women who are pregnant have a higher incidence of domestic abuse. And one of the patients that came onto our service, unfortunately, went home one day, and during a domestic dispute, she was shot, and she was shot in her face. And she had to come to the hospital. She was pregnant, and one of the other chief residents, in order to stabilize this patient, we had to perform an abortion under the guidance of the ethics committee, under the guidance of her family, because there's no other option. She has a brain injury, and they can't really perform all the life-saving heroic operations without getting the pregnancy out of the way. And that was in our hospital, in Reading Hospital, and then the patient had to get shipped to another hospital for safety concerns and for a higher level of care. So those are all some of those like horrible situations that we unfortunately have to deal with on a regular basis. It's not very rare, believe it or not. It happens regularly. You have a few of these horrendous situations every single year. But that's some of the things that we always have to think about, and we're always consulted for those situations. There's also high-risk pregnancy. That's another thing that I have to deal with on a regular basis. And to kind of give you a little vignette, I had a 32-year-old woman. This is her 5th pregnancy. She's about 26 weeks-ish, and she is Jehovah's Witness. And Jehovah's Witness patients don't accept any type of blood product. There are a very fine list of certain procedures and products that they're willing to receive. This woman had a certain type of blood type. Every single blood type comes in, has 4 different letters, either A, B, AB, or O. Don't really care about those letters. But then you're either positive or negative, and that's the rhesus antigen. If you're positive, cool. If you're negative, that's a problem when you're pregnant. Because if you have any blood from the baby that enters the mother's circulation, the mother can mount a response and then create a whole bunch of antibodies. Every single pregnancy, after the first pregnancy where you had that maternal-fetal hemorrhage, is sensitized. And so if that baby then has the wrong blood type, what will happen is that mom's blood will start attacking the baby, and it will cause a whole bunch of issues, specifically with fetal anemia. And if you have a super anemic baby, then you're gonna have a whole bunch of other issues, specifically congestive heart failure, ascites, pleural effusions, that type of stuff, but in a fetus. You treat horrible anemia with transfusions, and there's fetal transfusions that we do regularly as well. But you have a Jehovah's Witness mom who no longer wants to receive transfusions, doesn't want her baby to get intrauterine transfusions. And so we were now posed with this ethical question as to what do we do in this situation. This was also going to be her 5th C-section, and she was also anemic herself. That's a high-risk procedure because every additional C-section poses additional surgical risks and blood loss risks. And so now we're in a position where we have a high-risk baby, a high-risk mom, no one wants to get blood, and we have to then consult the ethics committee again, maternal-fetal medicine, the general obstetrician, and hematology oncology, so that we can make a decision to help this mom figure out what she's gonna do, okay? And in the process of this, she ended up leaving against medical advice. We tried to transfer her to another care center after she came back in. And she ended up delivering at another institution. The baby had to be in NICU and got blood transfusions because the mom refused blood transfusions, but then the neonatologist said, we're going to take custody of this baby at this point because it's a life-saving procedure. It's now a ward of the state. Baby needs a blood transfusion. And so there's other certain things that we have to take into account whenever you're talking about high-risk pregnancy. These are just issues that we deal with on a regular basis. So, and then contraception. Contraception is like a daily thing for me. Every single day, someone will come to me to talk about birth control. And it's not just birth control to prevent pregnancy. It's birth control to control bleeding. It's birth control to control pain. But the main thing is there are groups of physicians who are excellent physicians who have certain religious proclivities that prevent them from feeling comfortable giving out contraception. And in those cases, they have to do the appropriate thing and refer out to another physician that will provide those. It's not just birth control pills, but this is performing tubal ligation, sterilization procedures. And so part of reproductive justice, reproductive rights involves educating the patient about what you can provide for them and what you can't provide for them, and making sure that you give them access to a person that will be able to provide something that you cannot provide. And then we also talk about infertility. That's one major thing that women come to me for, is that they've been trying to get pregnant for years, whether this is a young woman that's never been pregnant or an older woman who has delayed childbearing until later after she finishes her career. And we try to do as much as we possibly can to ease the process, because infertility, subfertility, any of these issues come with a lot of emotional stress. Women want to have children if they want to have children. And so part of that is helping them understand what the risks, benefits, and alternatives are. If someone is unfortunately unable to have a child and we've exhausted all of our other options, in vitro fertilization, intracytoplasmic sperm injection, intrauterine insemination, we also have to link them up with people that work in the world of surrogacy or gestational carriers so that they're able to get their desired outcome. And so that's another thing. Like, we have social workers that specifically work in that world. And then the last part is that I want to talk about is women's cancer. I was actually late this morning. I was about to roll out the door, and then the general surgeon called me and said, hey, I'm about to take this gallbladder out. But I was looking in the pelvis, and there's a green mass that's in the pelvis. I don't know what it is. I don't work in the pelvis. You do. So I put some scrubs on, roll to the operating room, and then I take a look, and then I realize that she's a 38-year-old that has this green mucus mass in the pelvis. And when I'm talking about mucus, I'm talking about thick mucus. Do you guys remember GAC? It's like this, it's like silly putty. It was a consistency of GAC. You couldn't suction it. If you try to pour water all over it, sterile water, it didn't emulsify. It was just pure mucus. And the left ovary looked very, very abnormal. Left fallopian tube looked very, very abnormal. Right tube was normal. Right appendix, the appendix was normal. I looked at that and said, she probably has either fallopian tube cancer. There's a condition called pseudomyxoma peritonei, which is an appendiceal-based cancer. But as soon as I saw that, I realized I can't take care of this at this hospital in Skowhegan. And she needs to be referred to a gynecologic oncologist, which is a specialist in women's cancers in Portland. And so on the drive down here, I had to call the gynecologic oncologist and give a report to the attending physician at that time so that we can set up care for this woman so that she can get a cancer surgery. So there are the top five major killers in women is breast cancer, colon cancer, uterine cancer, cervical cancer, and ovarian cancer. OBGYNs, we got 4 of them. And so we spend a lot of time doing preventative care to rule out cancer, but we also do a lot of reactionary care. We have to, for example, today, she woke up, I had to tell her family, hey, I got called in, your surgeon's going to talk to you, you're going to follow up with me at 3 o'clock this afternoon. I'm going to make a referral to a gynecological oncologist. And so we do a lot of coordination of care so that we can take the best care of women. There's a lot of other topics I didn't really touch on today that I specifically take care of. I do a lot of transgender care. I get referrals specifically for that. I do a lot of infertility-based procedures as well as treatments. And then I do a lot of surgery. I love doing surgery, and that's one of my top favorite things in my job. So what kind of questions do you guys have? Concerns? Yeah.
Partly an answer why women part.
Yeah.
Do you think
there's been these stigmas that have been placed on surgical subspecialties. There's a lot of people say, oh, surgeons are men. They associate surgeons with men. And so they think some people will think like, oh, it's easier for a woman to get into a women-based specialty. But as I see regularly in my class, like all the people that match into urology for my class were all women. And there were, of the 9 of us that matched into OBGYN, 7 of us were guys. And so do I feel like they feel like they have a better opportunity? I don't really think so. I think it's becoming more of a choice. I think maybe 20 years ago, I would say it's more of like an opportunity, like, oh, I'm going to go towards this field just because I feel like I'll be better accepted in that specialty. But nowadays, I feel like it's changed so much. Now we're slowly getting, like, men in gynecology slowly becoming a little bit more equal. As of right now, it's 70% women, 30% men, approximately. So in gynecology. So questions? Yeah. Also, please.
I was just wondering what about surgery. What about surgery makes you going back from what?
So I'll tell you about the types of surgeries that I do. So I do pelvic surgery, and as a pelvic surgeon, you work on specific organs. So the most basic thing that I do is tie tubes. Tying tubes takes 5 minutes. There's ovarian surgery if you have ovarian cysts, and we do that laparoscopically. And so you put very, very small ports, 5 millimeter ports in, and then you're able to go in through those in a camera and then operate. And so I think that part of it, like laparoscopic surgery specifically, is fun to me. I played video games as a kid. This is somewhat like the ultimate video game. You have to practice a lot. And then we have the rule of like watching game tapes, which is every single surgery that you do, we record it. I record every single one. I have a copy on my external hard drive of every single surgery I've done maybe in the past 2 years. Just so you can look back to see what you could have done better. And so it's a strategy-based thing. It's one of those things like unlike playing like a board game where there's a lot of stuff based on chance. This is a game of strategy. And you can learn something with every single encounter you have in the operating room. Hysterectomies are something that are interesting because the hallmark surgery of a gynecologist is the vaginal hysterectomy. General surgeons have to go through the abdomen to get their target organs, whether it's the liver, gallbladder, or the bowels. They have to make an incision on the abdomen, and that hurts. Women have another access point, which is the vagina, to get at the uterus. And so I can essentially make one incision in the vagina and extract the cervix, uterus, fallopian tubes, and close everything up. And there's not a single incision. So I think it's a cool access point to get into the abdomen. Then I also do a lot of vaginal surgery. And the vaginal surgery is generally pelvic organ prolapse stuff. Things aren't in the right spot. So we're going to help tuck everything back in so you don't feel like you're sitting on a ball. You don't feel like there's tissue coming out. And then I do bladder stuff. So bladder slings, and those are helping women who have issues with coughing, laughing, sneezing, and losing urine. And then chronic pelvic pain. So some women have endometriosis, and endometriosis is a condition that is tissue that is usually found in the uterus that is in the wrong spot. And it is still responsive to your hormonal fluctuations every single month. And what that results in is growth of abnormal tissue in the wrong places, causing cyclic pelvic pain. And the way you treat it is cut it out. And so, and that just requires just a lot of care and careful dissection. And yeah, that's what I get a kick out of, just like carefully dissecting stuff out, like revisiting all my anatomical landmarks, and then getting the job done. Like, to cut is to cure. So.
Yeah, I don't want to take.
Okay. Yeah. Yes.
So, and that.
So in my case, there was autoimmune inflammation against different, what do you call it? Different types of tissue in my body. And what was happening was what's called a transidate. There's an exudate where fluid is pushed through a tissue, and then there's also other cells that are in it. Then there's a transidate, which is just fluid pushed in, but there's nothing that's also pushed. There's no white blood cells, there's no bacteria or anything like that. So in the case of Still's disease, there's just autoimmune attack of the peritoneum, which is essentially the skin lining the inside of your abdomen, the pleura, which is the skin lining the inside of your chest, the meninges, which is the skin lining the inside of my brain, and there's also, I think it was my right knee that also had fluid building around that as well. But what ended up happening was, with the inflammation, my body started shunting all the fluid towards the areas of inflammation. And they started accumulating in my abdomen, my lungs, and then it also subsequently resulted in my heart not functioning properly. So, yeah. It wasn't actually, there wasn't any pericardium. They did an echocardiogram to make sure that it wasn't. So, but my ejection fraction was low. So I'm not really sure what was going on, but that'd be a cardiac tamponade. So I'm not really sure. Yeah, but it wasn't the hepatitis was autoimmune hepatitis, and it was just more inflammation of random tissues in my body. The disease attacked my eyes, the skin. I had a hemolytic anemia, so it attacked my blood, so my blood started breaking down. Rash, so I had like a rash, so it was dermatologic as well. So it literally just goes after your entire body. So, yes, sure, okay,
So I'm
okay. Cool.
will ask me back. So like
Yeah.
So I wanted to ask.
Okay.
How
Yeah. Yeah. So that's a great question. I mean, like, I'm from Kentucky. I was an Indian guy that grew up in Kentucky, so that's kind of like, that's weird in and of itself. And then I went to medical school in Kentucky. Did a clinical research degree in New Orleans and Tulane, and then after that went to residency in Pennsylvania. And then I was going to start a career in academic medicine. I was going to be a clinical instructor, assistant professor, and that's what I thought I wanted to do. The issue was that I got sick, and then I hadn't taken care of any of the stuff on my bucket list, and so I was thinking, like, where can I do the most amount of outdoor activities and mark stuff off my bucket list? And there's a random few spots here and around the United States, but like Maine was on my list of places. Like, I always wanted to go to Acadia National Park. My family had an America the Beautiful pass growing up, and so all of the national parks were in the western United States, the majority of them. But I've never been to Maine. I heard Acadia was beautiful, and so going off of that, I signed up for a travel doctor agency. So just like there's a staffing agency, there are agencies out there to place travel doctors everywhere. My company was called Comp Health. I literally just Googled locum tenens. Locum tenens is Latin for to take the place of. And there's locum tenens physicians, locum tenens nurses, respiratory techs, etc. And this woman that picked up the phone happened to be the person, the physician representative, the agent. And she said, okay, we're going to help you find some jobs in these certain states that you wanted. I chose like Washington State, Alaska, Oregon, Maine, just random places that I didn't really know about, hadn't really been to. And this company literally pays for everything. They paid for my DEA license so I can prescribe narcotics. They paid for state licensure. They helped me. They essentially packaged everything together, mailed it to me. I think I paid like $4 for like a pack of stamps for the entire process to actually get the job to come up here. And they arrange different jobs with different hospitals. If there's a hospital that is in need, if there's a practice that is in need for any type of physician, they then call one of these staffing companies. They say, we're looking for one person. They need to work 8 to 5. They're going to be on call every other week, and they need to do surgery. We need them to be able to do everything. Then this company, as a staffing agency, will then find these doctors and then place them. And then you show up. I showed up on July 31st, was on call at 7 a.m. that day, and then that's it. My very first job, I was already on call day one. So, and that's what kind of brought me up here. Honestly, I got sick, looking for adventure. I got placed in Skowhegan, Maine. One of the best experiences of my life. So it's been really nice. I've been to Acadia a whole bunch. I walked on a short segment of the Appalachian Trail. I went skating on the river, on the Kennebec River, cross-country ski a little bit. It's kind of all the stuff that I want to do. It's been really pleasant, and I'm going to apply for jobs in and around the area for right now. Just kind of figure out what's going on. I think I want to stay a little longer. And so I kind of told my agent, I was just like, find me some other jobs in and around the area. I think I'll be in good shape. So, yeah, that's what brought me up here.
I have a million questions,
Sure.
and I'll ask them other
Sure.
times, but I'll ask one sort of physiology-based question. So, in still disease, what's the physiological origin of the
Brudzinski.
Yeah.
Yeah. So there's two different signs that are very specific to meningitis. Okay. There's the Koenig sign and the Brudzinski sign. When you have meningitis, you have excess amounts of fluid that's slowly building up from either inflammation, transitation, or exudation. It's usually an exudate, meaning there's pus that's in that space in the cerebrospinal fluid. If it's a bacterial meningitis, and that accumulates super fast, and that's what kills you from bacterial meningitis. That's why it's so dangerous. With viral meningitis and autoimmune meningitis, you end up having slower accumulation of fluids to the point that you can actually intervene, tap that fluid, remove it, and then decrease the pressure. Whenever you're moving around and using your body, that cerebrospinal fluid will shift. And so whenever you bear down, whenever you perform a Valsalva maneuver, whenever you cough, laugh, sneeze, you increase the pressure in your abdomen, but you're also increasing the pressure in your head. And so that maneuver hurts. There's also positions that you can put yourself in, such as curling your body. And when you curl your body, you essentially stretch out the container of the CSF in your spine. So it actually opens up and lengthens out the space that the cerebrospinal fluid sits in. And by curling your body, you're lengthening it up so you can decrease the pressure. And that's why that's why you kind of like hunched over like this to keep that space lengthened. Yeah.
So does that mean when people extend that it exacerbates the problem? Compartment will have the or when they back to extended.
Yeah. So when you're say that lot. So give me.
So you curl up and you expand the
Yes.
compartment, but you're still getting the CSF production
Mhm, yes.
And that pressure, the transudate pressure is going to go to a certain equilibrium or steady state, right? Where you reach that steady state pressure on a larger volume, but then when you relax the body back, bring the body back to an extended, reducing the size of that compartment, but you have a larger volume than you would have, because does that potentiate loss of consciousness?
Yeah, and so what can happen is that, so what you tend to see whenever you have meningitis and there's lots and lots of fluid is that you slowly get into the fetal position. And this is just, I mean, the position, the Brzezinski is like the precursor to getting into the fetal position, because it helps lengthen everything out. But as soon as you extend back out, you're shrinking the space, and then any extra fluid will continue to build up. The volume is still the same. And worst case scenario, you have what's called a herniation of your brain. Your brain sits in a cavity. There's a very, very small opening for your brainstem. And if there's too much pressure, your brainstem can push out and extrude through a very small hole in your skull, and that's instant death. So, yes.
Well, thank you.
Thank you. And if anyone's ever interested in coming, shadowing, and visiting the hospital I work at, feel free. If you're interested in showing up and checking out what we do, I'd be more than happy to see you. Yeah. So.
Thank you. There's a little gift.
Oh, cool. Thank you.
Thank you so much for coming.
Thanks. And there's another person coming over, right?
What's that?
Are you guys going to be talking about that skull thing?
Yeah. So it'll be Livia and Andy.
Oh, cool. I'm going to stick around for a few minutes.
Yeah.
I wanted to. Here's this other thing that my friend